Chapter 4 specifically gets into the US healthcare system and really what makes it unique, the various components of this, and how that compares to other countries. So, when we talk about the US healthcare system, a lot of what people attempt to do is say whether or not it's good or bad. And it's difficult to say whether or not it's good or bad. Some will argue that it's good. Because it's very advanced in terms of the technology that's utilized, very advanced in terms of the facilities available. Some will argue that it's bad because it's very expensive. I think what we can really, the conclusion we can come to is that the system is very inefficient. We spend by far more than any other country. We spend twice as much as most other developed countries. Um, Most would assume as a result of that, our outcomes would be better. Unfortunately, our outcomes are average, or in some cases, they're even worse. When it comes to life expectancy, infant mortality, especially something like obesity and chronic disease, we're not doing well. And so clearly, when we're spending as much as we are, and we're not getting those outcomes, something is wrong. Okay, and it's holding us back from progressing on a lot of other important issues in terms of social issues, infrastructure, all those other things. Okay, and why is this the case? Really, the system is very disjointed. There's a lack of leadership. There's poor communication. There's a lot of players that are involved who have varying priorities. Some people want to serve the general public, others want to profit off of the general public. And again, we have a very diverse culture. We have a very large geographic area. And so it's difficult to determine which programs will match everyone. Medicare, Medicaid, and now the Affordable Care Act, those have continued to struggle to fit into what is mostly a private healthcare system. The mix works for some, but many other people, this mix is not affordable. It does not provide a high quality level of coverage. It does not provide good access. So there's a lot of problems for many Americans. So the following is going to be a general overview of how the US healthcare system works. We're going to examine healthcare finance, access, quality of care, and then we'll look at some comparable healthcare systems. Okay, this is a slide that's a little bit updated compared to the one that's already there. Um, and if you look at the data on the original slide, that's on Canvas, and now this updated slide, it's not a good trajectory, okay? Compared to other countries, the numbers that you see, especially in terms of the percentage of GDP, that's almost double. So Canada typically hovers around 10% of gross domestic product in healthcare. Why? Canada has universal healthcare coverage. They have a government-sponsored healthcare system, which we'll cover later on, that costs quite a bit less. Now, many will argue that Canada's system is not as high quality as ours is. Canada probably wouldn't argue with that, but it's a heck of a lot less expensive. And so there's a trade off here. What are we spending so much of this money on? Hospital services, number one, and physician and clinical services. Typically, we're spending a lot of money when a person has a condition already or they suffer some type of an event. People getting cancer, having heart attacks, having strokes, and all the care involved in that is very, very expensive. And so we're spending a lot of money on treating people, and we're spending very little, if any, money on any kind of prevention. We spent a lot of money on technologies. We spent a lot of money on pharmaceuticals as a treatment option. We're seeing numbers in terms of chronic disease going up exponentially. Things like diabetes and heart disease are expensive to treat. We have an aging population. We have the baby boomers who are continuing to move through our culture, and they are reaching that retirement age, and there's a lot of them. Okay, and there's a lot in terms of administrative costs, as far as legal fees, as far as paperwork, as far as electronic medical records, and that's what leads to a lot of this cost that you see on the slide. Getting to the point where 20% of gross domestic product, we've been nearing that in recent years. That means one out of every, or 20 cents out of every dollar spent in the United States is spent on healthcare. So that includes defense, that includes all the spending in this country. 20% would be spent on healthcare based on our current trajectory. Okay. The attempt to address this was the Affordable Care Act. And so, according to the book, an estimated 93% will be insured once the Affordable Care Act is implemented. That did not occur. Um, there are millions of people that have become insured as a result of the Affordable Care Act, but it did not do what was intended, and that is maybe some flaws in the way that that law was put together. Um, it could also be some flaws in terms of the way it's being rolled out, and it was rolled out in 2012, and since 2017, we have a different administration handling the Affordable Care Act, or Obamacare, and that program, or the insurance coverage through that, is not promoted quite as well. We have things like the Children's Health Insurance Program, or CHIP, that are part of this. We have people with insurmountable medical bills. That's considered one of the top reasons people declare bankruptcy. That's actually the CNBC link that's at the bottom of this slide. Estimates are that we are currently around 90% of the population with some type of health insurance coverage. Now, that was prior to COVID-19. And so that number is probably gone down multiple digits. Okay, so we've had about 40 million people that have potentially lost their health insurance coverage. So that 90% number has gone down considerably. The assumption is once those people become reemployed, they will have health insurance. Once again, I don't think we can come to that conclusion. Okay. The largest percentage of people in the United States that have health insurance have it through their employer. So this is the problem when we went through this most recent economic downturn. Um, People lost their jobs and they lost their health insurance. And clearly, when there's a pandemic going around, that's not a good recipe for a healthy population. And so typically an employer will get private health insurance that they can offer to their employees. We'll get into that and the details of that a little bit later on. A smaller percentage of people have coverage through Medicaid, CHIP, Medicare, the VA, or the Department of Defense. Those numbers are going up, though. So an increasing percentage of people have public health insurance. That is because we have an older population. We have income disparities that are pushing more people toward Medicaid. These programs, Medicaid, Medicare, CHIP, those are run through federal or state programs. We'll get into the specifics on that later. The specifics of every health insurance plan vary considerably. There's a monthly premium, there's a copay, there's deductibles that people have to meet, there's insurance coverage limitations. We'll get into that later on. In terms of who is eligible, for private insurance, this is current or former employees. For public insurance, it's those who are qualifying based on various conditions. For Medicaid, it's their financial status. For Medicare, it's their age. For both those programs, there's certain people who are disabled that will qualify. For the Affordable Care Act, it's a lack of insurance coverage or poor insurance coverage. And again, the medical bills that people have when they don't have insurance are a lot of the reason that they will eventually declare bankruptcy. Okay. In terms of healthcare finance, now we have a whole class dedicated to this that Matt McKinney teaches, but just a couple things here. Services typically are provided to the programs you see listed on the slide. Those are provided to vulnerable populations. Okay. And those may be publicly or privately funded or both. Okay, so we have federal and state governments paying for these. We have taxes paying for these. This helps fill in the gaps of the healthcare delivery system. One of the things in the 1960s that was noticed was, hey, if a person is going to retire and they don't have access to their employer-sponsored insurance anymore, how are they going to live and maintain a high quality of life? That's where Medicare comes into play. Okay. Federally qualified health centers, these are typically located in medically underserved areas, so low-income areas, both rural and urban. They provide primary care on a sliding fee scale, which is dependent on income. So some communities have these clinics that people can go into where it's a very low cost for them. These are specifically for patients that are uninsured or publicly insured, but don't have the access that they need. Okay, there's HIV and AIDS programs that can be used without insurance coverage or any kind of financial resources, and this is federally funded and state funded. And there's also family planning services. This is for women who don't qualify for Medicaid. This does not include abortions, okay, but it may include contraception, screening, counseling. And so there's, in addition to private insurance, Medicare, Medicaid, you do have some other programs out there to help fill in the gaps for certain populations. Okay, healthcare access is one of the biggest issues that we're going to talk about, and I'm only going to mention a few things on this slide, but this is a big part of our conversation in this course. Many do not have a health insurance offered through their employer, or they don't qualify. And so this was a bigger problem prior to the Affordable Care Act because many employers dropped their health insurance coverage for their employees because they couldn't afford it anymore. Too expensive. Okay. The Affordable Care Act attempted to step in and address that, and we'll get into that later on. Many people can't afford the deductibles. Many people prior to the Affordable Care Act could be denied health insurance coverage because of pre-existing conditions. Okay. But there's a lot of reasons why people can't access health insurance, and that's why we're going to have such a high number of people that are uninsured that we're going to see later on. Okay. One of the key differentiators in this class is differentiating between the uninsured and the underinsured. Okay. Many people who are uninsured or underinsured are poor. They have a low level of education. They may be non-native to the United States. They may be fit into what's referred to as a minority population. They may be very young or very old. Typically, these populations have less access, they have less timely care, and they adhere to plans in a more in a poor fashion. Okay, there's a variety of factors that play into healthcare access. Number one, a lack of insurance. So if a person does not have insurance because they're unemployed or underemployed, if they don't qualify for public programs, if they're undereducated, they're mentally ill, they may not have health insurance, meaning they're not going to go to the local hospitals because the services are going to be unaffordable. So if you've ever seen a bill prior to insurance kicking in, you'll know those can be hundreds, if not thousands of dollars. Okay. Individuals in these cases cannot pay their bills and don't pay their bills, and in many cases they go bankrupt and the cost of care overall goes up for everyone. Geographic locations have a big impact on healthcare access. Urban areas, typically people, especially in urban areas that are more wealthy, they're going to have a lot of access. Lower income areas, especially low income rural populations, people are really struggling to find local clinics and hospitals. There's language and cultural barriers that limit access. Sometimes people don't trust the healthcare system because it's different than their culture. Sometimes they don't understand a particular prescription or a recommendation because they don't speak the language, they don't speak English. And maybe that facility doesn't have someone who speaks another language such as Spanish. Okay. There's also issues in terms of access related to provider shortages. In many cases, certain communities are lacking nurses and doctors. Some of this has to do with the aging population. You actually have doctors and nurses retiring, and we don't have enough people to fill in the blanks to replace them. Okay. Here's a couple key points though for this slide. Not all of the uninsured are unemployed. Actually, 70% of people who are uninsured actually are employed in some form. They just don't qualify for insurance. According to the Affordable Care Act, anybody working more than 29 hours should be offered health insurance. So what many employers do is cut off people at 29 hours and don't allow them to work any more than that. Okay. Not all employers offer health insurance. Okay. We actually, right before the Affordable Care Act went into play, we actually saw a really steep decline in the number of employers offering health insurance. And this was magnified by the economic downturn in 2008. We're probably going to see the same thing with the issues with COVID-19. Typically with the uninsured, these are low-income people who cannot afford insurance. They work for smaller businesses or are self-employed. In some cases, they are young adults. The Affordable Care Act did expand dependent coverage from age 23 up to age 26. That helped. Okay. Typically, uninsured people have a lower level of education. Race or ethnicity often plays into people being uninsured. There's a greater proportion of minorities that are uninsured. 34% of foreign-born residents are uninsured, and this becomes especially problematic among non-citizens. Keep in mind, if a person's coming from Europe or Mexico or wherever, those countries have universal health care. And so the idea of buying into or getting health insurance and paying for that is very different. We also are dealing with geography. More people are uninsured in the South and West versus the North and Midwest. And some of that is income based, some of that is culturally based, some of that is based on politics. Um, Many people who live in the North and the Midwest have opportunities for state based health insurance programs. And there's a lot of variation in terms of income across this country, in terms of access. The underinsured, then, is about 25 million people, and this has increased significantly in recent years. These are individuals that have health insurance, but that insurance coverage doesn't provide nearly enough. And that coverage cannot cover the gap between what they make and what they can afford. Okay. And what this results in is people delaying treatments and then ending up with a more significant procedure as a result of that. Rather than going to the doctor and getting preventive care, people wait until an event occurs like a heart attack or stroke. And clearly that's much more expensive. And what happens is the costs get shifted from the provider of the healthcare insurance to the individual. And so what we've seen is over the course of time, health insurance companies are shifting more of the cost to the insuree. So if you're going to go out and get private health insurance, you're paying more than probably what your parents paid as a proportion. Okay. In terms of healthcare access, a couple more things. Insurance limitations impact access. Sometimes health insurance companies won't cover certain things. For example, chiropractic care. Sometimes a health insurance program won't cover that, and if that's really the solution for a person's issue, they may have to pay for that out of pocket. Psychiatric care, obstetrics. Sometimes that stuff is very limited or excluded from a plan. That clearly can create issues for individuals. Cost sharing really varies from plan to plan. Typically, an insurance plan consists of 4 different types of cost sharing. Premiums are typically a monthly cost for a person to be enrolled in a program. This is shared between the employer and the employee, and that might be a 50-50 split. So for example, if the access to a plan costs $1,000 a month, the employer pays 500 of that, the employee pays the other 500. Okay? The amount in terms of premiums has increased exponentially. And when you look in the book, I have it listed as figure 4-8. Those costs have gone up considerably. Okay. Deductibles are the amount the insuree pays out of pocket before the insurance kicks in. And this can vary for the type of service. This is administered annually, and typically deductibles are in the thousands of dollars. For example, if a person has a $2,000 deductible on their health insurance, that means before their insurance will kick in and start covering certain costs, they have to pay $2,000 out of pocket. That's in addition to their premiums. So the premiums don't apply to the deductible. So I have a monthly fee in my premium. I have a $2,000 deductible. I pay my access fee, the premium, and I pay $2,000 out of pocket. Then my insurance starts to cover certain costs. In addition to that, co-payments are an out-of-pocket cost that patients pay when they receive services. This could be $15 to $20. This could be for a prescription. This could be for a doctor visit. That is, again, above and beyond any kind of premium or deductible. And then, in addition, the other type of cost sharing is a co-insurance. This is a percentage that the insured must pay for a service. So typically, once the deductible is covered, in my example, it was $2,000, a person may pay a 20% co-insurance. So if a person's met their deductible and they get a $500 bill, they're going to pay out of pocket 20% of that, and then their insurance covers the rest. Okay, so they might pay $100 out of pocket. The insurance company pays $400 in co-insurance. So premiums, deductibles, co-payments, co-insurance. Make sure you review that if any of that doesn't make sense. One of the biggest issues, and depending on the type of profession you plan to go into, there are typically some reimbursement and visit caps. And plans will vary in terms of what they'll reimburse for specific services. And that becomes really problematic for a doctor or a nurse practitioner or a physical therapist who's going to bill an insurance company. They may not get reimbursed very well for what they did, and that may make them not want to take that type of insurance. Plans may limit the number of visits that they'll cover. So for example, if you have a health insurance plan that allows for physical therapy, okay, great, but it may limit the number of physical therapy sessions to 6. That is not nearly enough visits in order for that to be really effective. Typically, rehabilitative services are very limited by insurance companies. And so you have reimbursement limits, you have visit caps, and that is a characteristic of insurance, and that has only worsened over time. You also have service exclusions. There may be some type of partial or full exclusion of a service. So anything that's very high cost, long term, or potentially what's considered unnecessary may not be covered. A stem cell transplant, family planning, or an abortion. An insurance company may not cover that. Okay. There's also some workforce issues that we have to consider. Shortages are extreme for primary care and for public health. I've already mentioned doctors and nurses. Fewer people are choosing general care, and much more of, especially the primary care providers, they're choosing a specific specialty. Okay, why? More money, more control over their careers. And the Affordable Care Act potentially could make those things worse because you have more insured, which means more are seeking care. So there's just more people in the insured pool. The shortages are more specific or significant in rural areas. The Affordable Care Act does include provisions to address these shortages by delivering professionals to underserved areas. But again, how much that's being done is unknown. Okay, so this is an issue for the insured, for the underinsured, and for the uninsured completely. Okay, estimated 200,000 fewer physicians and 1 million fewer nurses than necessary by this year, 2020. Okay, the population continues to age, especially those who are primary care providers themselves. They're retiring, and there's not enough people to fill in that space. Okay, so we're ending up with providers concentrated in specific parts of the country, while others are left without any providers. Mississippi has 42% of children living in what are considered low supply areas. And rural areas, as I mentioned, are particularly susceptible. Only 11% of physicians practice in rural areas. Okay? That applies to dentists, nurses, primary care providers. That's why we're seeing such a major uptick in the number of physician assistants and nurse practitioners. Okay? So the US, in terms of quality, really, if you're sick or you need treatment, it's very high quality. If you need prevention, not so much. Okay? The US is a sick care system rather than a healthcare system. We're great at treating a condition once it's present, but we're much worse at preventing that condition altogether. Okay? Patients are not receiving appropriate medical care, and why is that? The Institutes of Medicine provides 6 areas for improvement. We need to improve safety, cutting down on medical errors that could result in as many as 100,000 deaths annually. We need to improve efficacy using evidence-based practice. We need to focus on patient-centeredness, being sensitive to needs, values, and preferences. Being culturally sensitive is a big part of this. Okay, providing information that patients understand and addressing any language barriers. Being timely with care, decreasing waiting time for all services. Being more efficient, so utilizing resources optimally with very little waste. decreasing variations in costs based on location, geographic areas, and being equitable, eliminating health disparities. And that will actually be the focus of one of our chapters in this course. Okay. The last thing we're going to do here is compare the US healthcare system then to other countries. So Canada's system is actually referred to as Medicare. So don't get confused there. Canada's universal healthcare coverage is called Medicare. It was established in 1968. It is, they had a system very similar to the US private system prior to this. It provides universal coverage. Any medically necessary services are free, and people pay for this with their taxes. So free is in quotes there. The government is able to negotiate any kind of reimbursement rates with their physicians. The provinces and territories have their own response for their delivery systems in terms of policies and hospital reimbursements. They administer some single payer systems within those provinces. And the government handles the following: any kind of prescription drugs, public health, and research. And actually, many of the highest levels of prevention research are done in Canada. Dental, vision, and over-the-counter drugs and any kind of alternative medicine is considered private. But there is supplemental insurance that's available. Tax revenue pays for 70% of Medicare. So again, we say free, but people are paying for this system with their taxes. Right? The UK system, or Great Britain, they passed the National Health Services Act of 1946 to create the National Health Service. So this is essentially run by the government, and it's universal. The government provides healthcare that is free at the point of service, so people don't have copays. Regional health trusts then manage the services and disperse funds. So we saw that with the Canadian provinces, and so various regions of the UK, they manage this individually. The NHS is the largest publicly financed health system in the world. They have private supplemental insurance available to those who want to reduce wait times and have a higher quality of service. Many of the practitioners in the UK are private, independent contractors, so they don't work for the government. But the NHS itself, or the government, owns the hospitals and they employ the staff. Okay? Germany, this was the first healthcare system established in the world by Otto von Bismarck in 1883. The government controls the social health insurance system. Okay? Many recent reforms have attempted to improve the quality of the German system and increase access. And so the German system is also a mix of public and private, but it's essentially an income cutoff. Anyone making less than $60,000 annually has to enroll in the social health insurance system, or SHIS. Those individuals can also purchase supplemental insurance. Anyone in Germany making more than $60,000 annually for 3 consecutive years can opt out and actually go with private insurance. 10% of the population of Germany opts out of the universal coverage. Okay, why? Quality, access, reduced wait times, things like that. So the wealthy can essentially opt out of the universal coverage in Germany. Care in Germany is provided through both public and private sectors. Employers and employees contribute to a sickness fund to cover various services. So it's similar to the US system, but a little bit more efficient and a little bit simplified. Okay, but the issues continue to mount for all of these countries. I did want to mention, before I get into that, some of the rankings in terms of the World Health Organization. They consider France to have the best health insurance coverage. You see how much they're spending on their GDP compared to that to the US. Italy being number 2, the UK, which we've already gone through, they're 18th. Germany, who we went through, is 25th. Canada's 30th, whereas the US 37th. Okay, and again, compare GDP as a percentage and the amount the amount we're spending per person. The system is just very, very efficient. We're spending more, and we're 37th. Okay, according to these rankings. Okay, but some of the issues amongst these countries tend to be common. Okay, affordability is still an issue in all these countries. Access is still an issue. Wait times are still an issue. Okay, and low-income residents still tend to experience issues in all of the countries that we've covered, including the U.S. Right? So that's it for Chapter 4. That's a lot of information. Make sure you pause this, go back, and have a grasp of a lot of this information that we've covered. Okay.